Hello, my name is Jorge Viana. In this video I'm going to explain about the cranial nerves topic focused on the most important thing for your Step 1 exam for USMLE. This is Project PIMG from New York. Welcome and here we go. Main points: origin of the nerve, type of the fibers carrying, anatomy, function, test of importance, lesion, reflexes, olfactory, optic nerve, oculomotor nerve, trochlear nerve, trigeminal nerve, abducens nerve, facial nerve, vestibulocochlear nerve, glossopharyngeal nerve, vagus, spinal accessory nerve, and hypoglossal nerve. Olfactory nerve 1. Origin, anatomy, smell receptors or nasal mucosa. Sensory fibers enters the skull via cribriform plate of ethmoid bone. Olfactory bulb, olfactory tract, piriform cortex, temporal lobe, and B. Only sensation that does not relation the thalamus. Function, smell, test, ask the patient to smell, coffee and soap. One nostril each time, other side occluded. Lesion, anosmia, trauma, and skull-base fracture. Tumors, e.g. meningioma, etc. Optic nerve 2. Origin, anatomy, ganglion cell layer of the retina, optic nerve. Enters the skull via optic canal along with ophthalmic artery and central retinal vein. Optic chiasm, optic tract, occipital lobe. And B. Node of peripheral nerve from diencephalon, oligodendrocytes, not Schwann cells, affected in central demyelinating. Demyelinating disease, e.g. MS. Function, vision, afferent limb of pupillary light reflex. Test, pupillary light reflex. Snellen chart, visual acuity. Confrontational test, visual field. Always test one side each time. Optic nerve 2. Lesion, ipsilateral complete vision loss, all fibers, ipsilateral visual field defects, some fibers. Reflex, pupillary light reflex. Oculomotor nerve 3. Origin, anatomy, medial midbrain, motor nucleus, motor fibers, centrally. Eden-Westphal nucleus, parasympathetic fibers, peripherally. Enters the orbit via suborbital fissure with cranial nerves 4, VIII, 6. Function, motor supply to majority of extraocular muscles, SR, IR, MR, IO. A. Movements. Motor supply to levator palpebrae superioris, elevates the eyelid. Parasympathetic supply to sphincter pupillae and pupil constriction. Parasympathetic supply to the ciliary muscles, lens accommodations. Motor quality central. Parasympathetic quality peripheral. Oculomotor nerve 3. Ischemic injury. Diabetic neuropathy. Affects VEII, nervorum. Microangiopathy. Early signs: eye looking down and out, ptosis. Late signs: dilated pupil, compression injury, PCOM, aneurysm, uncal, herniation. External compression of the nerve. Early signs: dilated pupil. Late signs: eye looking down and out ptosis. Horner syndrome. Components: ptosis, meiosis, anhidrosis, more or less enophthalmos. Etiology: injury to the sympathetic supply to the eye. Oculosympathetic paresis. Sympathetic supply to superior tarsal muscle, aka Mueller's muscles. Elevated the ale. Pupillary light reflex. How to test it? Trigger: shining a light in one eye. Look for a response in both eyes, direct and consensual. Efferent sensory line, optic nerve. Efferent motor line, oculomotor nerve. Parasympathetic fibers to the pupil constrictors. Normal response, pupil constriction bilaterally. Abnormal responses: relative afferent pupillary defects, RAPD, unilateral lesion in the routine optic and optic nerve, shining the light in the affect A, delay constriction in both A's, shining the light in the normal A, normal constriction in both A's. Efferent pupillary defects, unilateral oculomotor nerve palsy, shining the light in the affected, constriction only in the normal A, shining the light in the normal A, constriction only in the normal A. Trochlear nerve 4. Origin anatomy. The smallest of all cranial nerves, motor nucleus in medial midbrain, motor fibers exit post midbrain fibers crossing, aka RT nucleus damage affects left superior oblique enters the orbit via suborbital fissure, suboblique muscle SO4 function. Motor supply to the superior oblique muscle is O4. Eye looking down and in EG reading going downstairs with intorsion, lesion. Diplopia on looking down and in nose side with a head tilting to the contralateral side, RT trochlear and A affection, a head tilted to the left side to compensate for loss of intorsion. Trigeminal nerve 5. Origin: the largest cranial nerve, nucleating lateral pons, medulla, and cervical cord. Main nucleus of trigeminal, mesencephalic nucleus, spinal nucleus of trigeminal, motor nucleus. Anatomy: three divisions. Ophthalmic V1 enters the skull via S of F, efferent line of corneal reflex. Maxillary V2 enters the skull via foramen rotundum. Mandibular V3 enters the skull via foramen oval. Trigeminal nerve 5. Function: ipsilateral general sensation, e.g. pain, touch, temp, from the face, cornea, maxilla, and mandible. General visceral sensation from end to free of the tongue. Motor to muscles of mastication, masseter, temporally, med and lead, pterygoids, and belly of diagastric myeloid and tensor palati. Motor to tensor tympani, deadening loud sounds. Lesion: V1, loss of corneal reflex sensation from upper face and scalp. V2, loss of sensation over the maxilla. V3, loss of sensation over the mandible. Chewing weakness. Jaw-bien, towards the affected side. Trigeminal nerve 5. Reflexes: corneal reflex. Trigger touching the cornea with piece of cotton. Aftersensory line V1. Efferent motor line. Cranial nerve 7. Normal response bilateral blanking. Jaw reflex trigger. Place your index on the middle of the patient's mandible and tap on it with a hammer. Efferent V3. Efferent V3. Normally no response. Bilateral UMNL. Lesion above V3 nucleus. Jaw jerking upwards. Trigeminal nerve 5. Trigeminal neuralgia. Tic dolores definition. Sudden recurrent sharp, severe pain involving half side of the face, mostly V2 or V3 territory. Triggered by talking, chewing of very short duration minutes. Dot. Carbamazepine, antiepileptic medication used for neuropathic pain. Versus migraine. Definition. Pill-sparing unilateral pain associated with nausea, photophobia, and photophobia. Triggered by stress, menstruation, overactive area, focal reversive neurologic symptoms. DOC, acute, NSAIDs, acetaminophen, triptans, ergotamine, prochlorperazine, metoclopramide. Prophylaxis, any CGRP, amitriptyline, topiramate, valproate, botulinum toxin, and beta blockers. Abducens nerves 6. Origin anatomy. Motor nucleus in medial pons. Motor fibers enters the orbit by suborbital fissure. Function. Supply lateral rectal muscle. LR6. A. Abduction looking away from the nose. Lesion. Diplopia on abduction of the affected eye. Test. CM3, 4, and 6. Eye movement in all directions, elevation. Examine a single eye each time. Facial nerves 7. Origin. Motor nucleus lateral pons. Subsalivary nucleus. Parasympathetic. Nucleus of structure salutaris. General special sensory. And the only fibers of facial motor nucleus which supply the upper face have dual UM innervation from both cortical sides. UMNL on one side affects only the lower face on the contralateral side. Anatomy. Exit the cranium via the internal auditory meatus, middle ear below the styloid process, divide into its 5 terminal branches: temporal, zygomatic, buccal, mandibular, and cervical. Facial nerve 7 function. Motor the muscles of facial expression, obliquaris, oculi, motor to stapedius and middle ear, motor to post, belly of the gastric and styloid muscles, lacrimation, salivation, submandibular and sublingual, taste sensation from end to 3 of the tongue, chorda tympani, general sensory from a small area behind the ear. Facial nerve 7, lesion. Bell's palsy, LMNL. Idiopathic viral HSV1 affects whole side of the face. Resolves in a short period of time. Ipsilateral facial weakness, inability to close the eye, raise the eyebrow, show teeth. Hyperacusis, i.e., inability to tolerate loud sounds, loss of corneal reflex, efferent Lyme. Other causes of LMNL, Lyme disease caused by Borrelia burgdorferi. UMNL affects only lower part of the face of the contralateral side of the lesion. Fascian nerve 7. Reflex, lacrimation, trigger, corneal irritation, efferent sensory Lyme, ophthalmic division V1, efferent motor Lyme, CN7, parasympathetic, normal response, lacrimation. Vestibulocochlear nerve 8. Origin anatomy. Sensory fibers from the inner ear enters the skull via internal auditory canal, cerebropontin angle, vestibulocochlear nuclei, lateral pons medulla. Function: hearing, balance and equilibrium with compensatory eye movement. Lesion: sensorineural hearing loss, vertigo and nystagmus. Glossopharyngeal nerve 9. Origin: nucleus tract solitary general special sensory, nucleus ambiguous shared motor nucleus with CN 10 and 11. Lateral medulla inferior salivary nucleus, parasympathetic. Function: general visual sensation from the oropharynx, tonsils. General and taste sensation from post 1-3 of the tongue. Salivation, parasympathetic to the parotid gland. Motor, stylopharyngeus muscle. Efferent Lyme of carotid body. Sinus reflex, which helps regulate blood pressure. Glossopharyngeal nerve 9. Lesion: loss of gag reflex, loss of sensation from post 1-3 or the tongue, ipsilateral oropharyngeal sensory loss. Hemodynamic instability, high BP and HR due to misperception of low BP. Vagus nerve 10. Origin: dorsal nucleus of the vagus parasympathetic, nucleus ambiguous shared motor, nucleus obstructus solitary sensory, lateral medulla. Function: swelling, main motor to the pharynx is kept stylopharyngeus and by glossopharyngeal nerve. Main motor to the pelt except tensor palati and by trigeminal nerve. Phonation: main motor to the larynx, sensory from the larynx and laryngopharynx. Parasympathetic to the foregut and midgut. Increase peristalsis, secretion and relax. Sphincters. Efferent Lyme of gag reflex, efferent Lyme of carotid body, sinus reflex. Both afferent and aortic arc baroreceptor reflex, which also regulate BP, general and taste sensation from the root of the tongue. Vagus nerve 10. Lesion, dysplasia, ipsilateral pylorial drop, hoarseness of the voice, loss of gag reflex, loss of cough reflex, deviation of the uvula, and anyway from the affected side. Hemodynamic instability, unopposed sympathetic, gag reflex, to gag or to not gag. Trigger, touching the palate, root of the tongue, one side each time. Efferent sensory Lyme, glossopharyngeal M. Efferent motor Lyme, the vagus M. Normal response, gagging, throat muscle contraction, belt elevation to prevent aspiration. Spinal accessory nerves 11. Origin anatomy. double origin, cranial portion, nucleus ambiguous in a lateral medulla, molar nucleus, spinal portion, cervical spinal cord, travel cranially, dot foramen magnum, join the cranial fibers, exit the skull via jugular foramen, together with cranial nerve 9 and 10. Function: supply the trapezius and sternocleidomastoid muscles. Test lesion. Trapezius and equality ask the patient to shark the shoulder against resistance. The shoulder against resistance. Ipsilateral weakness. Sternomastoid M equality turns the head to the same side and the face to the opposite side. Difficulty with turning the head against resistance on the same side. Hypoglossal nerve 12. Origin anatomy. Motor nucleus in medial medulla, motor fibers. Exit the skull via hypoglossal canal. Function: motor supply to all tongue muscles, except palatoglossus muscles, supplied by the vagus nerve. Test lesion. Ask the patient to protrude the tongue. Normally, left side muscle protrude the tongue to the right side and vice versa, so left hypoglossal nerve lesion, e.g. medullary syndrome. Tongue deviation to the left side, i.e. deviation toward the same side of the lesion.